Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
So I welcome one and all in tonight's class. Namrata being the speaker for nausea, vomiting in pregnancy, but she's not the only one. Remember, all of us are in this together. So the entire class is going to help her out and help yourself as well. Every case that we're doing is for everyone in the class, like I always say. And again, I start the class with giving a lot of congratulations, a big bear hug to all my students who have recently cleared their DNB theory, and now within couple of weeks they have their practical exam. So I'm really sorry could not be joining a lot of you in the class tonight, but yes, I'll be doing that as soon as possible, probably tonight itself, and we'll be looking forward to more interesting case discussions with more students around. All right, Namrata, over to you. You can start your case. Yes. Yes, Namrata, you can unmute and speak.
Hello. Okay. Good evening, everyone. My topic is nausea and vomiting in pregnancy. Coming to patient profile, her name is Mrs. AB, 26-year-old, wife of Mr. YZ, residing in Calicut. She's a homemaker by profession. Educated till 10th standard. She's a preemie gravida. Her last menstrual period was on 10th May 2025, and her EDD was on February 7th, 2026. She is 8 weeks, 2 days of gestational age by LMP. Her present.
Okay. Just a second, Amrita. First of all, whenever you're speaking like this, that she's a primary gravida, her LMP was 10th of May 2025, that's fine. Making her EDD, that's the language, making her EDD on 17th Feb 26, keeping or presuming that she's having regular menstrual cycle, or on inquiry with a regular menstrual cycle, her EDD falls on 17th of February, making her current gestational age 8 weeks, 2 days. That's your language, always.
Okay.
Or when you're speaking about LMP, so and so, making her EDD 17th Feb, keeping in mind her regular menstrual cycle, making her current gestational age 8 weeks. Okay. Yeah.
So her LMP is 10th May 2025, making her EDD 17th February 2026, and her gestational age 8 weeks 2 days, since her menstrual cycles were regular.
Yes, very good. That will give your examiner an edge, especially when you see this is a very normal basic question when you're asking patient when was your last period. At that time only you ask whether your periods were regular. No? That's it.
Yeah.
So even if the examiner inquires, oh, you took the menstrual history right now, asking the regular periods, is yes, sir. Because I'm making the EDD, I need to know her cycles were regular or not. Otherwise, my EDD will be wrong.
Yes,
you are not at all wrong. In fact, I think anybody will be impressed when you say these lines. Yeah, go on.
Okay.
So her presenting complaints are.
So she's complaining of repeated episodes of nausea and vomiting since 2 weeks, and inability to take orally since 2 days.
Mm-hmm. So, like I always ask all my students, I've put this DD for you here. Tell me one thing, that when you're talking about a patient who has come to you with nausea, vomiting in pregnancy, are you presuming that this could be only physiological nausea, vomiting in pregnancy? She's haven't not been able to take orally since the past 2 days. Is that the criteria? Is that what happens usually in pregnancy? Does it happen that way, Namrita?
No, ma'am. We have to consider all the other possibilities also, like gastroenteritis, and
Yes.
then we can also think of conditions where the HCG is more, because she's having severe vomiting. We can consider molar pregnancy, multiple gestation. Then if the gestational age is a bit more, then we can also think of preeclampsia, health syndrome.
Acute fatty liver pregnancy usually happens later on, in the second or third trimester. But you can mention these things, because what I learned from my exams that I gave, there is always a DD based on the symptoms, not the entire total symptoms together. So she's complaining of nausea and vomiting, okay, but she's in early pregnancy. So you start with the most likely diagnosis first, and then keep speaking about nausea, vomiting in pregnancy, no matter what. So your examiner might intervene in between and say, does it? Do you think preeclampsia it will happen right now? So no, sir. But this is also one of the DDs. You are not wrong in giving that DD. Absolutely not wrong in giving the DD. AFLP, not wrong in giving the DD. So yeah, these are pregnancy-related DDs.
Should I mention somewhere, or just in negative history the possible other symptoms should I rule out, or should I
You
mention?
will go to negative history, Abhi, Namrata, because right now this is my question to you. What are the DDs you're keeping in mind when you will take a negative history? Because in exam, the examiner will not stop you here to ask you DD. They'll ask you towards the end. But for me, DD is very important right at the time patient has given you the symptoms, because now your history will be asked in such a way. You discuss DD right now, you discuss DD towards the end. It doesn't matter much. I can do the same thing again. I mean, I can repeat the DD later on for you, because so many things you'll be able to draw. But it's so important. You think about it yourself. If somebody comes and gives you some history, you start thinking immediately, what could it be? Yes or no? To be very honest. The DD comes right in the beginning. It doesn't come towards the end. It is what I feel, I think, is one of the lacunae when you're like asking like an examiner. Almost all of them ask towards the end. That is the time at which you've almost made your diagnosis. So what's your likely diagnosis? DD is right now. At the time when she's come to you present the symptoms. That time you've started thinking, oh, what could it be? She's coming to us with such a level of nausea and vomiting. Mostly it looks like hyperemesis gravidarum, but why would she have hyperemesis? What is the reason? Multiple gestation, molar pregnancy, maybe a family history of hyperemesis. She herself is having some issues. Okay, maybe she already had a liver problem. She already had excessive, gas and gastroenteritis, or she's recently had something from outside. So then your questions will start hovering around these DDs that you're forming right now, right? So yes, right now you're just thinking. This is not what you'll write in your, that sheet of paper which you're supposed to speak in front of the examiner. But this is what you're thinking right at the time she gave you her symptoms. Yes.
Okay. So, history of present illness. The patient started having nausea and vomiting since 6 weeks of gestation, with gradually increasing frequency. She had vomiting 3 to 4 times per day initially. Now it has progressed to 6 to 8 times per day over the last 2 weeks. It was non-projectile, non-bilious, not blood-tinged, and contains only ingested food. It is associated with fatigue, reduced appetite, and weight loss. She was complaining of weight loss, ma'am, loosening of her clothes and all. And there is no history of fever, rashes, pain, abdomen, dysuria, increased frequency of micturition, passage of loose stools, heartburn, regurgitation of food, intolerance to heat or cold, palpitations, etc. There is no history of
Just
yellowish.
hold on. Yeah, Namrata, I don't think I have those slides with me right now. Just a minute. Let me first make their basics clear. So we spoke about the obstetric causes because of which she can have excessive nausea. Definitely one is nausea, vomiting, and hyperemesis. Both are different conditions. We'll be dealing with them shortly. Molar pregnancy will lead to these things. Multiple gestation will lead to this. Preeclampsia is not exactly correct DD over here because it's later on, if at all it is. Acute fatty liver can happen at any point in time, mostly in the second trimester and third trimester. But anytime, any other cause, which might not be obstetrical in nature, like ovarian torsion or fibroid, certain other causes like maybe she's had food from outside, like I just said, gastrointestinal gastroenteritis, anything like peptic ulcer, gastroesophageal reflux. So you have to ask whether she's had similar episodes before or not. She's been having heartburn history, GERD history. She'll tell you that, right? She already is a patient of peptic ulcer, so she has exacerbated now. Pancreatitis, appendicitis can happen at any point in time. It's not necessarily early, late pregnancy. It can happen anytime. It will look like nausea, vomiting in pregnancy, but actually the cause is something else. So you have to ask about pain in abdomen, upper abdomen, lower abdomen, any other issues. She's not able to put down her food. That can happen at any point because of appendicitis, because of cholecystitis, pancreatitis. So these DD has to be kept in mind. This is not very common, but yes, metabolic causes could be a possibility. Okay, metabolic causes, endocrinal causes, pyelonephritis, UTI, that can happen anytime. Usually these will have fever as well. So you have to ask that as well. So when you're asking her negative history presenting illness, you have to make sure that you ask all these things, right? So first we'll discuss what Namrita has written, and then I'll tell you what more should have been written over here. I think Namrita, you have one more slide for your negative history, which I could not include because it came a little late. But we can discuss it no matter what.
So can
you
I
said that
repeat my negative history, ma'am?
Sorry?
Can I repeat my negative history, ma'am? I have, I
I'll
think.
just go one by one and then I'll ask you about your negative, the ones which we don't have here. Okay. So
Oh.
patient started having nausea vomiting since 6 weeks. And that was gradually increasing in frequency. And now she has progressed to almost 6 to 8 times a day vomiting over the last 2 weeks, which is non-projectile, non-bilious, not blood rich, and contains only ingested food. And what is the reason why you've written this down, Namrita?
Ma'am, non-bilious because no, projectile vomiting may be affecting the CNS and all,
Yes, yes,
and
absolutely.
non-bilious because from where the vomiting is coming, we can like from.
Yeah, no problem. It's okay. She's been taking food and the food is coming out. Okay. So
Yeah.
it's not that she's retching and only bile is coming out. Bile is coming out means there's nothing in the stomach, right?
Yes,
It's
ma'am.
empty stomach. Just bile is coming out. She's not really, she's NPO. But I think this was the quality of her vomit earlier on. Since 2 days, she's not been taking, I think, anything, right? Whatever she takes, she just throws it out.
And
So it's
blood
non-BS, okay. Not
syndrome.
that that means it's just a recent episode, because sometimes if it's cold, then she'll start vomiting. Because of so much of retching, she can also have a little bloodage, or it could be some other esophageal varices or something, or peptic ulcer or anything, so that she has blood vomit. Okay, agreed. It is associated with fatigue, I can see. Reduced appetite, I understand. Lightheadedness, and somewhere you said that she has lost weight. Now she's not taking this thing. Putting down her solids or whatever foods in the past 2 days. I think this is what was your initial history, correct, Namrita?
Yes, ma'am. Now she's not able to have anything normally, ma'am, of food or fluids or anything.
Okay, so she's saying that she's lost her weight. Now, this is a very important point, because as you will proceed with the history of nausea, vomiting in pregnancy, you will see that when you're talking about the last puke score and then management of this patient, weight loss is a very crucial part to say that this is one of the complications. So whatever the puke score is, if it has got even one complication, we take it as a serious consequence, and then we divide this patient into inpatient care most of the time. Okay, complications mean the patient has to be dealt with inpatient. So she's losing her weight because of the loosening of her clothes as per the patient. So we can presume what she's saying is right, and weight loss, even 5%, is considered significant when you're talking about patient with nausea vomiting. You have to take it seriously. Then you asked about no history of fever, rash, pain, abdomen, dysuria, increased frequency. Now this gives multiple DDs. Yes, tell me, Namrita, what are you looking forward to here?
Okay, ma'am. In increased frequency of micturition and dysuria, UTI, ma'am. Then pain abdomen, it can be like appendicitis, so
Gastritis, peptic ulcer, pancreatitis, yes.
pancreatitis, appendicitis. Then even abruptio placenta is a DDM, ma'am. I
Don't
read.
say all these things here. It's too early and not right to
Even
specify all these
this
things. But
appendicitis,
yeah,
UTI and all, fever also will come, ma'am. Then then I've also added in my new slides, ma'am, regurgitation of food, heartburn, and
no
then
history. No history, right?
yes, ma'am, no
Okay.
regurgitation of food, intolerance, then intolerance to heat, hyperthyroidism,
Okay. Okay. Yeah, you can say.
and
And
palpitation.
that can happen at any point in time in pregnancy.
Then there is no history of yellowish discoloration of urine, clay-colored stools, itching, liver
So,
dysfunction.
yeah, this just say that she's got no history of any liver disorder. That's it. No urine color, no stool color, nothing, no itching, pruritus, no, nothing. Just give a history that she's got no history of any liver disorder ever. That's it.
No
Because liver is a very important part here.
Then no history of headache, visual disturbance, loss of consciousness, altered sensorium and seizures. Any CNS tumor or even migraine can have vomiting.
So
Or
all this, I'll make it easy for you. Preeclampsia, don't speak, because I don't expect you to, associate preeclampsia that early on in the pregnancy, and you'll be unnecessarily caught. okay, and it'll have a wrong impression on the examiner. So don't just omit this. I know we spoke about it in the DD, but we also negated it when we were speaking about it in the DD, isn't it? So you only said that, ma'am, had she been in the second trimester, this would have been an important DD. Yes, I agree with you, but she's not. Now we're back to our patient, okay? If they ask you DDs, you will speak preeclampsia. But if they say in your patient, things change. So when you're asking negative history, you're asking to your patient. You're not now talking to the examiner. You're not giving a list of DDs. You're now talking about your patient. So we will not ask her about this thing. Nausea, see, seizures you can still ask because that tells you any CNS lesion.
Yes, neurological.
So headache.
So can I
Headache,
include
loss of consciousness,
disturbance, loss of consciousness, altered sensorium, seizures, and all those?
disturbances that you can say, but
Okay.
do not associate it with preeclampsia at all. That could be just a simple CNS lesion. Yes.
Okay. Then she's not able to tolerate solids or liquids in the last 48 hours.
This is very important. Okay, two very important things: that she's not able to tolerate solids or liquids, and that she's had a weight loss of whatever amount, because she's saying that she's got loosening of fluids, and now we are suddenly very serious about it. This becomes an important part in the management. Yeah, you can go.
Ma'am, hyperemesis gravidarum, in the definition they are saying it will affect their daily activities. Should I write it in a history or just assume like
Yes,
that?
it is affecting her quality of life. Definitely, you can speak this thing. It is
So
absolutely
if
just.
I ask like a question, is this affecting your daily routine activities like that? Should I write it as a point?
Yeah, definitely. Very important point it is actually. See, in India, we don't we don't give a lot of weightage to the emotional quotient of the patient, how the patient is fighting or adjusting. We just see the medical part of it, right? But these guidelines are made in UK. So if you have read, all of you have read this GTG, you must have seen also there's a part which is mental status.
Yes,
And
ma'am.
it's repeated in every chart. Her mental status, because they think that once the patient has nausea, vomiting, she's very depressed. Anxiety is there, depression is there, she's not able to eat food, she's solitary, living in a confined to the bed, not able to have her favorite meals. So she's having a change in mental status as well, which is very important. So yeah,
Okay.
you can see
Okay.
that. Go ahead.
So his coming to history of present pregnancy, this was a spontaneous conception. Pregnancy was confirmed by urine pregnancy test at 45 days of amenorrhea. Antenatal checkups. She consulted in a nearby primary health center. From there, she was treated with oral medication for vomiting, and also she got folic acid supplements from there. She didn't do any investigations from there.
Okay, now yeah, please go ahead. Anything in this slide?
No, ma'am,
Anything
no
more?
history with rashes, radiation exposure, bleeding PV, no drug intake and substance abuse. Ultrasound also was not done. Only negative things.
Now tell me, all of you in the class, why and what point over here in this current pregnancy is very important for me, which I will be asking or stopping her on. Everyone in the class, please let me know what is the most important point which I'm marking in this presenting history, present pregnancy.
Ultrasound,
Yeah.
more multiple gestation and molar pregnancy we have to rule out.
Yes,
And
that's the point. I'm looking at what happened to the ultrasound. Have we got any baseline so that at least some of the DDs I can check out? But there was no ultrasound done. So I need to know why is she having such amount of, almost in the level of hyperemesis. Because most of the patients, they get nausea vomiting. Okay, 80 to 90% have nausea vomiting. Only some few 0.3, 0.5% they go into that hyperemesis category. Okay, so no, I need to know what exactly was the ultrasound. No ultrasound was done here. That is the thing. Yes, Namrata, we can go ahead now. And what are my other students doing tonight? They're sleeping. Where are the students? Now I'll ask you individually if you don't answer, guys. Okay, be alert because I didn't get any answer. So think fast and write faster. Yes, Namrata. In the next slide now.
history, ma'am. She's having her last menstrual period was on 10th May 2025. She had before that she was having regular cycles of around 28 days of duration, 3 to 4 days, and she used to use 3 to 4 pads per day. and there was no history of passage of clots, and she also didn't have any dysmenorrhea.
All right. So really, I don't get anything, specific from here. So menstrual history is fine, but marital history is okay. Anything specific you'd like to speak about medical and surgical history?